Hey everyone, this is Dr. Medicine Alex, and in today's video we'll be discussing about the pathogenesis of leprosy. This is a very complex topic where there are many intricate interactions of various cells of the immune system as well as involvement of different types of cytokines and chemokines. I've tried to simplify this, and I've also tried to mention the major important cells as well as cytokines that are involved in the process. So as we all know, leprosy is caused by acid-fast bacilli known as Mycobacterium leprae. The exit route for these bacilli is through the skin as well as the nasal mucosa, and the entry route is through nose, and rarely it is through broken skin. The average incubation period is 3 to 10 years. However, certain cases where the incubation period was as long as 30 years have also been observed. Coming to risk factors, low economic status due to improper diet, contaminated water, overcrowding, certain immunocompromised states, as well as patients on antiretroviral therapy are at risk for acquiring the infection because of the activation of subclinical infection. So as soon as the bacilli enter the body, they multiply in the dermal lymphatics as well as vascular endothelial cells. From there, they enter the circulation and hematogenous spread occurs, and then they are spread to the skin and peripheral nerves. The major target for the leprous bacilli are the Schwann cells that are present in the peripheral nerves, in that they attack the laminin 2 protein, and M. leprae, they have a specific laminin binding protein. Next, coming to the immune response that is seen, the spectrum of the disease, whether it is tuberculoid or lepromatous or in between, depends on the immune response mounted by the host. But as soon as the bacilli enter the body, the innate immune response gets activated. And this response, it is constituted by the NK cells, the dendritic cells and the macrophages. And these cells, they kill the bacilli. Now, as after they kill the bacilli, the dendritic cells and macrophages, they engulf the killed bacillary particles and then they present them via the MHC molecules to the T cells. Thereby, the acquired response sets in. So, this acquired response, which is constituted by the T cells and the B cells, is again a Th1 or a Th2 type of response, and it depends on the cytokines that are produced by the innate immune cells. So, the monocytes and the dendritic cells, they have toll-like receptors, especially the TLR1 and TLR2, which recognize the mycobacteria. And these cells, they further release Th1 type of cytokines, which are constituted by the TNF alpha, interferon gamma and IL-2. And these Th1 cytokines are seen in tuberculoid pole of leprosy. And the TNF alpha and interferon gamma, they further cause granuloma formation. Whereas in lepromatous leprosy, there is reduced expression of TLR1 and TLR2. Therefore, there is going to be predominance of Th2 cytokines, and these cytokines are IL-4, IL-5 and IL-10. These cytokines, they further cause B cell activation, which is humoral immunity, that is production of antibodies, and the IL-4 further inhibits the TLR2 activation. Thereby, there is no Th1 type of response seen. So the major differences or the major characteristics of the immune responses seen in tuberculoid and lepromatous leprosy are that in tuberculoid leprosy, the cell-mediated immunity predominates with CD4 is to CD8, a ratio of 2 is to 1, and there is going to be a Th1-like profile, and there is going to be production of pro-inflammatory cytokines, which are the IL-2, interferon gamma, tumor necrosis factor alpha and IL-12. There is going to be strong phagocytosis and granuloma formation. Whereas in lepromatous leprosy, the cell-mediated immunity is weak. The CD4 is to CD8 ratio is 1 is to 2. There is going to be a Th2 type of profile with anti-inflammatory cytokines constituted by IL-4 and IL-10. There is weak macrophage activation and poor granuloma formation. However, there is going to be a strong humoral response with polyclonal B cell activation and production of antibodies. However, it is important to note that these antibodies, they have no effect on intracellular M. leprae. However, whenever the captured bacilli or their products are released into the circulation, then the antibodies, they act and they also lead to immune complex formation. And these antibodies, they are also kind of like biological markers of infection, and they can be useful for diagnosis of the disease or for predicting subclinical infection and reactions. It is important to note that phagocytosis of M. leprae, that is just the engulfment part of the M. leprae, it occurs in both spectrums of leprosy. However, the organism, it is completely destroyed in tuberculoid leprosy by the innate cells, whereas in lepromatous leprosy, there may be persistence of the microvacuolated monocytes along with the bacillary debris. Therefore, we have to understand that phagocytosis, it occurs in both spectrums of leprosy. Next, coming to pathogenesis of nerve damage. Nerve damage begins as soon as the Mycobacterium leprae get localized in the nerve. Following the localization, there is going to be infection of the Schwann cell, followed by nerve injury, axonal atrophy, and demyelination. So demyelination, it occurs in the early phase of infection, and this is mediated by the phenolic glycolipid. There is going to be induction of cytotoxic immunity, whereby there is going to be release of perforins, granzymes, and granulysins, as well as activation of apoptosis through the fast-fast ligand or the tumor necrosis factor like receptors. Thereby there is going to be further demyelination. One another route by which Schwann cells can be affected is that Schwann cells, they may express self antigens following the infection by M. leprae, thereby leading to self reactivity by the T lymphocytes. It is important to note that this nerve injury, it can be acute or chronic, and it can continue even after the cure of infection. Thank you. Subscribe for more.